asked that because my background, just kind of give you an idea of where I come from and why I teach this course. I started out as a respiratory therapist. I moved on to paramedic, fireman in St. Johns County for a while. Had to leave that to finish up nursing. Started working with pediatric transports at Wolfson's. Then became a nurse and started doing the ICU. And then I started flying on helicopters. So before I got to school, one day I was an RT in the unit, one day I was a nurse in the unit, one day I was on life flight, and one day I was on the transport team. And on the transport team, you had to do a 40-hour intubation rotation. I tell you this because it wasn't until I got into school, anesthesia school, that I was humbled about taking care of airways. I thought I had a pretty good background. Well, it turns out the more and more airways you do, then the better you'll get at it, regardless. So I was very humble. So despite utilize what skill set you have, but just know that it's every day of a potential humbling experience. And the thing about basic airway management really hasn't changed much over the years. What has changed are the advanced adjuncts like glide scope, which is slowly becoming the new norm. Like I know at Mayo, some physicians want you to only intubate with a glide scope, and they're saying that's the standard of care. Granted, it's not actually the standard of care, but that's what they're choosing to call it right now. It is an adjunct to use, but I still believe in being able to use the old method because you don't know where you're going to go, if you're going to be in an austere environment or whatnot. So you need to learn the basics, and the basics we'll start with. We'll talk to you about what the basics we'll start with. So I'm sure some of you guys, I've added to this PowerPoint every year, so you may have a version. Who knows what version it's on now? I think I've done this for about 8 years, so we'll keep going. A lot of it's going to look the same. So when you look at basic airway, some of these things look crazy, but I'm sure you're going to sometime in your career come across something like this, and you're going to say to yourself, what am I going to do here? So I put these pictures in here, kind of food for thought, to let you know to think of what you're going to do in these situations. Some look easy, some don't look so easy. So after the PowerPoint presentation, when you're at home, I want you to go back to these pictures and say to yourself, what are you going to do in these situations? How are you going to prepare if you have time? And this is just an internet photo, none of these are mine. But just to give you an idea, so that's somebody that's had probably a carotid enterectomy. What can you do about that? That looks crazy. Somebody that's lost a lot of weight, maybe even some surgery, but you may not know that beforehand unless you do a good assessment. And that's why I put that one in there. Airway swelling. I'm going to run through a lot of this stuff quickly. I really think the nuts and bolts of this is the assessment portion. So you'll be able to go back and review the anatomy and physiology. I'll hit the high points, but I'm going to quickly run through those and some of these things here. So if I'm going fast in the beginning, don't worry, because what you really need to know in the practice is toward the end of the presentation. So airway management. You know, you want to prevent morbidity, mortality, but you also want to prevent these other things. You know, just probably 2 weeks ago, one of the students that we recently started taking students at our study center that we manage had a little dental damage. So there's no excuses for it. If there's any trouble, especially at a surgery center, there's no reason to keep going. Stop, bag the patient. Let's come back with plan B, see where we're going to go. There's no reason to create any type of damage in that situation. You have time. You're not going to bring a patient to a surgery center that has major issues. You're at an academic facility or a big private hospital organization. There may be instances where you have emergent situations. But even then, you have to be careful when you're performing an airway technique. And the biggest thing out of this slide that I want you to take away is the incidence of failed intubation is relatively low compared to difficult mask ventilation. When you guys are starting your airways, I really want you to concentrate on masking the patient. I cannot tell you how paramount that is, just to get a good mask seal. That is the hardest thing to do in airways, not intubate. When you get your first intubation, you're going to feel so confident about yourself. But when you're able to mask every single patient or know exactly how to call for help in that situation, that is really where I want you to be. That's where you choose yourself, because that is truly the most difficult thing. It doesn't matter if you have large hands, small hands, if you have, you will develop the techniques. I mean, there's people out there. I don't know if anybody been to Shams yet. Have you guys done any type of rotation? No. You'll meet one of my old mentors, Tony Thomas. She's about this tall, and she can do anything. In my opinion, she's that good, and that's kind of one of the things that she honed in on me as I was starting out. Was you need to learn how to mask. She'd slap your hand if you're doing it the wrong way. Okay, we won't do that anymore. It's getting a little more political now, but. Please learn how to mask ventilate. Let you guys read this. It's pretty much all the same stuff. Inadequate ventilation is kind of the higher settlement payments of adverse events. Again, we're going to squeeze through here. Basically, the thing out of these things are airway is becoming second fiddle to nerve blocks, things like that, with closed claim reports. So we're getting better at airways because we're getting better equipment. Now, what we have to teach you is the algorithm to get you from point A to point B, which is intubation, quickly enough. So we have to get your mindset right. And that's what part of my job is here today. And then whoever's teaching the advanced airway, whether it be Dr. Shores, Dr. Pavolati, or a combination of, they will get you to the advanced airway equipment. So put this slide in here because I agree, but I also disagree with this. And for the same fact that I've been talking about here just a second. So a lot more people in the field, either anesthesia, EMS, whatnot, transport teams made up of nurses and stuff, they all need to know how to mask ventilate. That's a great number of people. But not all of those individuals learn truly how to intubate. So yes, there's a lot of people that are expected to learn this technique, but the time required to learn it is greater. I slightly disagree with that. I think it takes longer to learn how to truly mask ventilate well in every situation. I can't tell you how many times, even now when I do OB, we're on the code team. And we go to a code and respiratory is there, and they're just smushing the mask in their face. And I don't see much chest rise. They don't put an oral airway in. They don't even raise the chin well. They're just sitting there. I'm like, I'm pretty sure that stomach's getting bigger and bigger. By the time, if they beat me there, I'm pretty sure that patient's getting ready to aspirate, vomit because of all that extra air. And had several do that. So now I'm trying to intubate, sometimes without suction because they don't have suction ready. So you're going to be put in these situations. What are you going to do? I had one where respiratory actually had a glide scope, but they were already bagging before I got there. Then they tried the glide scope, so I walk in, and next thing you know, here comes all this stuff, brown stuff just coming out. They can't see anything with the glide scope. That's fine. Give me a regular laryngoscope. They push on the belly, saw some air bubbles, put it in. That's all I could do because they didn't have suction ready. You get to that point. So I'm going to tell you stories throughout here of my situation and even friends of mine that I've had that had issues and what they did. But you're going to be put in these situations. What are you going to do? Every time you're in clinical and you're sitting there and everything's rock solid, put yourself in a situation and try to get yourself out of it, just in your mind. And if you kind of stump yourself, whenever your staff comes in, ask them, hey, what would you do in this situation? I did that all the time in school, and I asked a lot of questions. and I think it helped me out quite a bit. So again, with this slide, I think it takes a lot longer to truly mass ventilate somebody than it does to learn how to intubate somebody. We're going to just breeze through this. I think the high point says just know where the cricoid cartilage, that's probably a test question, kind of bifurcates the upper and lower airway. And I'm pretty sure you guys went through all this already. This slide, again, rote memorization, just learn it. The biggest thing to think about in this is that sympathetic superior cervical ganglion. When you put somebody to sleep and you want to, maybe they're obese or something, or you didn't have the greatest mass ventilation because of their anatomy. So maybe at the end of the case, you're thinking of, what am I going to do? Am I going to put oral airway in, or am I going to put a nasal airway in? I put this up here because, you know, when I was reading things, and I didn't learn this until probably I was midway through school, is that if you're going to potentially put in a nasal airway, me, I like to put it in earlier because of this situation here. Because you have this engorgement of nasal tissues, and you're less likely to cause trauma. Now, you can do it atraumatically at the end of the case, but you're more likely, as you're learning, to cause trauma at the end of the case because you're this superior cervical ganglion or depression of it in causing that engorgement. So, almost similar to putting a nasal trumpet in somebody that's pregnant. You know, pregnancy causes that engorgement of the airway. So, similar situation. I think, my opinion, this is the biggest thing to take from this slide. You should know everything on the slide. This is just the trigeminal nerve and the branches. Again, some more anatomy. We're going to keep rolling through this stuff. Tongue is one of the biggest potential for airway obstruction. Take home for that slide. I have no idea what your test questions are going to be, so you're responsible for all of this. We're going to keep rolling on through this. All right. When you talk about eliciting the gag reflex, just know it's a two-part system. The reflex is elicited by the glossopharyngeal, goes into the brain, comes back, and the vagus nerve is the one that causes the motor component of that reflex. You will need to know this, SLN and RLN, especially when you're talking about the motor component of the muscles to the laryngeal, when you're talking about laryngospasm. So this is important information here to know. So, and also if you're going to learn advanced airway techniques and do airway blocks, you need to know your innervation of the airway. Here's a nifty little slide. I thought this was great for that. Kind of gives you an idea of your RLN, SLN, and your components. Kind of gives you a little breakdown of your different nerves here. All this information is testable. This came from Morgan and Mikhail. Morgan's a lawyer. Great information here in your assessment. This is pretty good information here if you're looking to do a cricothyrotomy or even different blocks of knowing your landmarks. Hopefully everybody gets to see something like this on your first shot. You know, nice and pretty. Otherwise, guess what? You're probably down here in the esophagus. If you don't see something in that picture that looks like that, chances are you're looking at the esophagus. So you may not want to blindly insert. Again, we're going to roll through the anatomy and physiology. All right, starting to get into some more information that you definitely need to know. These are action board questions. Your 3 single cartilages and your pre-paired. This came from Netter's. A lot of these pictures, if you guys have that book still. It tells you where all the cartilages are. Ah, the vallecula. We'll talk about that in just a minute. So, it has to do with where you're going to place your blades. So, that little space between, right in here, oh, this blade not to be working that well on this. This little space here, you have two major blades, right? Straight blade and curved blade. So, which one's the straight blade? All right, curved is? Okay. So, curved blade goes in the vallecula, and you have to indirectly lift the epiglottis. All right? The straight blade actually directly lifts the epiglottis. So those are 4 questions, probably questions on this test. Go ahead and guess. All right, you're really more concerned about your intrinsic muscles, laryngeal muscles, because those are the ones that are involved with laryngospasm. And that's going to be very important to you. Does anybody know what a major complication of laryngospasm is? So let's just say you got a healthy young football player and they're coming through and you kind of maybe extubate them in that excitatory phase. And they go into a laryngospasm.
Negative pressure pulmonary edema?
Yes, absolutely. So it's real, and it can potentially keep the patient intubated for a long period of time, on oxygen for a lot longer. You know, there's several ways to combat that. Some people put them on PEEP. Some people give them a little bit of Lasix. There's some debate on the Lasix, but you know, it is definitely real, and you have to be careful of it. So, what are the 2 ways to extubate somebody, or what are the 2 areas in which you want to extubate them?
One and
Delivery or phase.
Either wide awake or they're asleep, right? But not in between. Otherwise, you're going to increase that risk of laryngospasm. Now, does anybody know the 3 major muscles that are involved with laryngospasm?
I read it yesterday.
Well, they're up here on the board, I can give you that much. Now, you just got to pick the right 3. Anybody? Anybody? Give a stab at it. That's one.
And then the top 2, the cricoadenoids.
The lateral crackoarytenoid and your thyroid. I don't think I have it in here, so you might want to write that down. Your lateral crackoarytenoid, your cracothyroid, and your thyroarytenoid. So these actually tense the cords up. These here are connected to your hyoid bone. So if you think about it, you have your insertion and your attachment. So that tells you at what point the 2 areas the muscles actually attach to it. So same with this right here. These actually help with phonation, swallowing, things like that. Yes, they're important, but not as important as the intrinsic for us. Okay. Again, netters. So what I did was I kind of turned this upside down because this is kind of what you would hope to see if you were looking at the vocal cords. This is kind of the internal view. You'll see all the different muscles there. Again, I'm not going to go over each individual one up here because that's kind of rote memorization once you go back to review that. Here's more of the muscles here and what they do. You have your abductors and adductors. And these are the major muscles here, and what actually they do. Don't care about the blood supply, but it's in here for your reading. Now, it starts going over the trachea. I think the biggest one here to learn is your cricoid ring again. It's the only complete ring. Now, with this, which side is going to be intubated more than the other?
Right.
Yes. So the left tends to come off more to the right angle. Always love this quote. So when you're out, you're tired, 3 o'clock, you're able to go home. Then comes this great case, potential airway case. I hope all of you say, hey, I'll stay, I'll do that case. And then you'll really learn a little bit more. All right, let's start getting to more of the nitty gritty of the assessment. Because this is the stuff that you're going to have to start to learn and know. So when you're looking at assessment, let's talk about history of the patient. If you have time to do a complete history. First off, have they ever had surgery before? And if they have they ever had any problems with anesthesia, airway, things like that? If they do, hopefully they were given a letter saying that you were a difficult intubation. And if they were, hopefully kind of describe, maybe slightly, what that difficulty was in the process. Have they ever had a tracheostomy before? Usually, you can probably see that on physical exam, you would hope, unless it was just a great closure. Do they actually have a medical alert bracelet? Maybe they were unconscious when they came to you, and it said difficult intubation. You may not know. They may say, yes, I have sleep apnea. Okay, well, are they on a CPAP or a BiPAP? What are their settings? I asked that question because I gauge their disease process with the settings. So if you have somebody that's on 5 of PEEP on the CPAP versus somebody that's on 12, or maybe they're on a BiPAP because the CPAP was issue. Maybe the CPAP wasn't enough, so they're on the BiPAP. These are questions to ask that some people don't think about. Well, if their settings are very high, there's probably a good chance that you may have a little bit of difficulty mask ventilating the patient, and or you may want to have their oral airway or nasal airway ready when you're going to put them to sleep. Any disease process within the airway itself that may preclude you from a normal laryngeal intubation. Maybe you need to do a nasal. Maybe you need to get some type of advanced airway technique up front. You want to consider awake intubation or use a fiber optic scope doing that. Just you need to look at this and start thinking of plan A, B, and C whenever you see any of these disease processes. Trauma. They have a tooth that's barely hanging on. Would it behoove you to go ahead and take it out once they're maybe you've already induced, take it out real quick and prevent that foreign body aspiration. Do they have any airway burns? Maybe they're coming in because they were involved in a fire and they inhaled some caustic steam or something. So now you're having some sloughing in the airway or swelling up pretty quickly, things like that. Chemical burns the same way. Radiation is one that you may not know until you get in there. It may look normal on the outside. You know, somebody that had any thyroid disease, maybe they radiated, but they radiate too much. These are things to consider. That's going to make it a little bit more difficult for you to actually do a laryngoscopy if they have that radiation. So you're going to see this information over and over. There's a reason for that. They want it ingrained into you. Do it, you know, in your sleep. So, incisor distance. What's the normal incisor distance that you want? Anybody know? Yeah. So, thyromental distance, 6-ish, 6 centimeters. Head and neck extension. You want somebody to be able to put themselves in a nice sleeping position. So kind of chin out. You know, when they're laying down, you don't want them necessarily with their chin up in the air. You want their whole head to kind of come back. And what that does is that opens that space up. We'll talk about Mallampati classification. Personally, I'm not a big stickler on the Mallampati classification because I don't think that people do it correctly all the time. They'll say, open your mouth. Then they'll say, well, that distorts your actual classification. You shouldn't phonate when you do the actual Mallampati. Okay? And the more and more I do this, I've seen more difficult airway with a good Mallampati. I think there's other factors, and we'll talk about that. The next thing would be body weight. I think body weight is a two-pronged. I think there's a lot of soft tissue in there that kind of distorts the airway. But also, I think it makes it a little bit more, a little tougher, actually, on the laryngoscopist to manipulate the head. Sometimes it's pretty heavy in order to do so. And again, here's that past history of difficult airway. So, predictive factors of a difficult airway. and I think this came from Nagel. But obesity, decreased head movement. If they have some type of strabismus or muscle rigidity in the jaw, there was and I'll just do this. So receding mandible, we'll look at some pediatric patients that have that, like a Piro band or something like that. And of course, prominent incisors. But there's this heroin laced with some kind of junk that's coming in. So again, when I'm on OB, we do airways in the ER, we do coach. So there's been probably a string of these heroin overdoses where they have this strong muscle rigidity. It won't break with succinylcholine. It won't break with other non-polarizing paralytics. But what do you do here? So we walk down to the ER and it's like, okay, what have you given? You know? So they said this, like, well, you might want to just go ahead and cut their neck. Nothing I can do to open their jaw. You've given everything that I would potentially give. So, and it's funny how they're waiting on you to do something as the patient's crashing, and it's like, you guys do more cracks than we do, so just cut the neck. But it's funny how some of the ER physicians are so scared to cut a neck. We had one patient expire, and one patient they promised to cut the neck. I did a study when I was doing my master's here, and it was about cricothyrotomy. And I think there was a ENT physician at Gainesville who pretty much said it only costs, you do a decent cricothyrotomy, it just extends their stay in the hospital 30 days. For me, that's not a bad deal. Just, done. There's ways to do it. To make it pretty simple. It's getting easier. They have kits now. You make a little nick and everything else. You just use a spreader so you get less bleeding, things like that. But, just put it in there. 30 days, but now you got somebody that's going to live, even though they're in the hospital for 30 days. Or you reduce the potential for brain damage and things like that, which will keep them in the hospital a lot longer. So for me, I have a very low tolerance to, hey, just put the neck, just do it, let's be done. So unfortunately, and maybe my company will help UNF do more cracks or learn. I think that's our next goal. We try to teach you guys the business of anesthesia, getting that going again. But I think our next thing is when we get SimLab open, maybe we'll get some big drinks and things like that, and we'll give you a good lesson on cracks. But I think more and more you have people going into austere environments. So whether you're military and you're going overseas and you're the front lines, or you're one of these fast teams or whatnot, or you're going to be in a rural area, I think that's a skill that you probably should have. That's just my personal opinion. It's not the same opinion as others around, but I like to have all the necessary equipment around, and that's one of them. Again, you're going to see these over. I put a bunch in here. So everybody learns slightly differently, so I put multiple ways of learning the same information in here. Here again, this is what I was talking about. These are some of the pediatric cases. You have your Downs that have a potential for subluxation of C1, C2, so you got to be careful with their neck. They have short necks, they have big tongues, big heads, make it slightly difficult to intubate. Most pediatrics, I would use a straight blade, but when I would get a Downs child, I would use a curved blade because they have such a large tongue. For me, it was easier to manipulate. I don't care what blade you use. I'm not going to, if you want to use curved, you want to use straight, I don't care. You might get a little flack from others to say, oh, you should do this. I think you should be proficient with all blades and all equipment. That's my personal opinion. And if you get the airway on the first time, that's what I would care about. So if anybody gives you any grief of using a different blade, just, don't worry about it. So it's, in my opinion, those are the individuals that pushing you in the wrong direction. Do what you need to do to get the airway safely and first time. But again, so you got that PRO band, have a really retracted mandible, and those can be kind of difficult. I don't know necessarily if I would consider a just a regular laryngoscopy with a laryngoscope. I would think I would use some type of fiber optic where I could see something. You don't necessarily have to use a true fiber optic airway or Gliscope. Take a look. Gliscope revolutionized what we do. It really has, and they have different types. You have McGrath. I mean, you have a King airway. There's so many different ones. You should try and use them all. Figure out what you like the best, because when you go to a different institution, it's all about price. So they're going to use the cheapest one, and you're going to have to learn how to use it. So again, more I have a good slide that goes a lot that really breaks it down. But this is worth the review. More congenital stuff, infections, rheumatoid arthritis. You got to worry about. Make sure they don't have any unstabilized neck joints, things like that. Tumors, any facial injury. Again, here we are with obesity, acromegaly, and then some burns. It's just a quick little slide. I'm going to talk about this one real quick because I have another slide in here that goes over this as one of the main factors. This is actually a really good one to learn. So again, you're going to look externally. You're going to look and see if their neck was ever cut before. Do they have a protruding incisors? Do they have recessed mandible? Things like that. Are they edentulous? When I see somebody and they have their dentures in, I don't necessarily take them out. Hey, I'll take them out. I say, do they usually come out? And if the patient says yes, like great, I'll leave them in, because for me, if I kind of press here and they stay put, I know I can bag a little bit easier, because when you're older, you lose some of that collagen in your face. So it makes it tougher to bag. Right here tends to go below the mask and allows for the seal to be broken. So sometimes I'll leave the dentures in. I know I can take them out pretty quickly. Even with now sometimes the LMA case, I'll take them out. If they say no, they don't come out really, if they don't come out easily, that's fine. I'm okay with that. I know I can take them out if I need to. You'll have some people that take them out all the time and then struggle to mask it. Or they'll use a two-person technique, which is fine, but just know that there's other easier ways to do it. So you want to really look at the patient, and then, like I said before, look at all those people that I put in their presentation earlier on and see how you do things. This is your look externally. Bull neck, those are kind of like a Downs kid or a big football player, or some lady that's on a lot of testosterone. Big neck, that can be potentially difficult to view, or a short neck. You don't get, and I'll show you here in a minute, your different axes that you need to put the patient in order to get a better view. This 3-3-2 rule, that's your mouth opening, your thyroid distance, your highway chin. Yeah, you pretty much do just incisor distance and your thyroid distance, which is your thyroid cartilage mouth floor distance. That's the same thing. Now, non-polysporting, I'm getting ready to show you. Obstruction, we'll have a slide that kind of gives you a better idea of obstruction and how to assess that. And of course, neck mobility. And they move back and forth this way, any problems that they are, or if they do have issues, now you have to think to yourself, will it resolve if I give them a paralytic? Is it a static issue? Maybe it's rheumatoid arthritis or something like that. Then you may have to ramp them or do something to put them in that right position if you can. And if you cannot, then you may want to consider an advanced airway technique if that's the case. So neck mobility is definitely very, very important. All right, here's your non-potty classification. Everybody should know this, right? You guys know it? You can not even look and tell me everything. All right, what are the 4 structures? Here.
Pillars.
So, soft palate, tonsillar fossa, your pillars, of course, your uvula. And then we're going to keep on going down as you lose these things. Now, look at class 2. If you tell them to phonate, what's going to happen? You're going to see probably class 1. So here again, that's why I say I don't really care for the Malapati classification. You need to know it frontwards and backwards. It's very dependent on the patient to do it well. If they can't do it well, then you're not going to get a true good scoring. And not many patients, unless they're a true class 1, when they just open wide, you can almost see the cricoid cartilage from just looking at them. Most of them just don't do it well enough. And so you may call them a 4, but they're really a 1. You know what I mean? So I just have issues with this classification.
Does the head have to be in a certain position? I've seen some people like
Sitting up,
Yeah, like
just
yeah.
come to open wide.
Like
And
just make
and
sure
stick
there's
the thumb all the way out as far as they can. Although what you can see when you do this is all the tongue rings. And I have the worst time in OB when I go do an assessment. I don't care, I'm doing an epidural at any time, they can be a general, anytime. So open wide, they have a tongue ring, got to come out, and man, they will fit your fit. So then I go down, worst case scenario, and they can't get it out fast enough after that. So just talk to them and let them know that, okay, fine, so if we have to intubate you, this could knock out by a laryngoscope, it could go into your lungs, called foreign body aspiration, cause you get really sick. And then, yeah, there's a possibility, right, I just don't, I think that's some arbitrary number, 50% of people die from this. There you go, thank you, have a nice day. And again, if it's a true good scoring and you only see a soft class 4, you can take a look with the laryngoscope, just know that you should have your backup readily available. This your Cormack-Maheen scoring or your grades. You'll see grade 1, 2, 3, or 4 view. This is depending on the provider that's doing the intubation. So once you develop your technique, the better you get at it, the better the scoring is going to get. It's kind of funny how that is. You go in there and your first intubation, you're like, I don't see anything. It's a grade 4 view. We need all this stuff. Then your staff comes in, they're like, see their toes. Okay. This is more dependent on as you get better. Once you're an expert, I think some people say once you're about 1,000 intubations, you're probably considered an expert. I agree. You get more and more and more, you get better. Again, I had all this experience before I got in the program, but I was extremely humbled after I started doing this every day. And I guarantee you, probably my first one was like a grade 3, and then my buddy Tony, she looks up, she shakes her head, she's like, give me the tube, you're not getting another shot all the rest of the day. So, but again, you'd hope to see the whole laryngeal aperture on your first shot. Some will, some won't. And then just the posterior aspect, just your epiglottis, then nothing but a hard palate. I'm sure you guys seen this. This was actually taken when we were in class, when our classes were taken at Shands. And we're waiting for Dr. McDonough to come to class. And while we were sitting there waiting for him, my buddy was, you'll get to meet him, Dan McEwen, was flipping through the news, and he sees this picture, and he blows it up, and look who it is. Now we know why he's late. So we waited a long time to show him this, and then it came out. I think I put it up in one of my PowerPoints in school. So, yep, that is actually him on his way from Yulee to Shands. Wow. All right, again, now we're going to talk about those that are difficult to mass ventilate. We talked about elderly and why they lose kind of collagen. Those who are edentulous, we kind of talked about that. Obese individuals, sometimes it's tough to get your hand to do a single hand technique. It's not failure to use two hands and ask somebody to bag for you. If that's what you have to do, that's what you have to do. In this game, all pride is set aside because you're the patient advocate. So you don't do it, get somebody else to do it. Next man up, let's go. Because you're going to take care of the patient, and that's all that matters. You're going to ask them if they're snores or if they have sleep apnea. A lot of people say, no, I don't have sleep apnea, but man, I snore. Oh, okay. So chances are they're just undiagnosed OSA. And then that kind of resonates in your mind. Well, how am I going to break up all this soft tissue in here? So, and it's not just your tongue in the way, it's this soft tissue that drops into the airway. Well, you may want to consider a nasal airway at that point in time, if it's pretty far down. Dry whole airway, if that's not working, for the nasal one. It's fine, let's do it. Beards are hard to get sealed. Two-hand technique works really, really well with somebody has a thick beard. So don't be afraid. Again, if your staff's there, got a big beard, I can't get a seal, I'm going to use two-hand technique, do you mind bagging? Okay. It shows that you have the thought process ahead of time that you know what you're doing, and that's what you got to have. You'll learn about somebody has some type of airway obstruction. Now, there's a difference between stridor and true wheezing. Stridor is usually upper airway. What's in there? The foreign body. Is there some type of pathology in the airway as far as that's making them sound stridorous? So these things to consider. Tell you what, man, that would kind of pucker me up. I see this guy on my table. I was like, well, I might use a two-hand technique here. Don't forget, you're going to have other adjuncts. We'll talk about that in a minute. If you can't mask them straight up, maybe you want to consider using LMA. Laryngeal mask airway. You know, slip that bad boy in. You can breathe it down a little bit more and then pull it out and use a laryngoscope. So these are patients with an increased risk of aspiration, i.e. you get somebody from the ER, whatever, they've taken some medication, now they're obtunded. This is what you might assess for. And so there's, how do they put it? There's those that need airway protection, and which are those with aspiration. And then there was another, it was a study from Canada, I'm trying to think of it, I just read it a couple of days ago at the other, how they put it, and I really liked it. I'll see if it's in one of these slides coming up. So, you get a patient, it's almost story time. I'll just tell something. So, I had one of my classmates who was up in Boston, and had a 30, she's in her mid-30s, we'll just say 35, old lady, had a small bowel obstruction, and was coming straight up for surgery. And the ER tried to put in a NG tube, but the lady wasn't having it. So they told the patient, ma'am, we're gonna have to put this in. We got into your stomach gut. So they got it in, and they sucked her belly out before surgery. Well, they put her to sleep, rapid sequence. Sucked, broke the ball. They were holding cricoid pressure. Everything they're supposed to do. They had suction readily available. They had a glide scope ready. They took one look with the laryngoscope. And as soon as they pushed all the drugs, the sucks took effect. They opened it up. Everything from that small bowel, it relaxed that and started gushing out. She coded. Within 30 minutes, she was on ECMO. They could never get her off ECMO. They did everything right. They did everything they could. But she eventually passed away. Off ECMO, they couldn't get her. But that hit her that quickly and made her that sick. So it's no joke. Be prepared for anything and everything. And it haunted him for quite a while. He called me up and he asked me what I would do, and I said, I wouldn't do anything different than what you guys did. You emptied your stomach. You were available. You were there. You did everything the books tell you to do. What else could you do? She had to go to surgery. So that's one of those unfortunate cases that happen, and you have to get over it, and you're going to kick yourself, and you're going to ask yourself all the questions. Do this differently, do this differently. Now it's just an unfortunate situation on a healthy female with a bowel obstruction. So we talked about uptunded individuals. We talked about those with full stomachs. If you have to cancel a case because of full stomach, cancel the case. You know, they live to see another day. If it's an emergency situation, let them know there's a high risk that this could happen. What is it called if they have aspiration? What is that syndrome? Mendelssohn? Yeah. That should come up the next slide. So this is going to be a board question, probably on your test. So there's a, I always thought this was funny because there's two main medications that you give with somebody that has a potential for aspiration. One of them was, or three rather. One of them is Reglan. What does Reglan do?
Prokinetic.
Increases motility.
Increases motility. Zantac, what does that do? And then third one is Vicitra. So that neutralizes all the acid that's already in the stomach. So the Zantac kind of stops the production of acid. Right? Then you have your Vicitra that neutralizes everything. But according to this slide, you know, you have an increased risk of aspiration if you have any more than 20-25 ml. But Vicitra is 30 ml. Will they shoot? No, I'm not slow slipper because it's awful. I'm going to shoot it like a shot. But I think the risk of the caustic risk of any acid outweighs the volume that you're going to get. Personal opinion. It works immediately, and I use it quite often in OB. And some people don't, but if you're in a C-section and they're kind of like burpy, gassy, whatever, you give that and immediately done. It's amazing. So I really do think it outweighs that potential risk factor. So it's a very, the Mendelssohn syndrome, again, it created such an inflammatory response in my buddy's patient when she coded and went on ECMO that it's a real deal. So you have to really assess for this. You know, how bad is your GERD? You know, do you take things regularly? What do you take? Are you on prescription or not? Things to consider. Because if they're laying there for a long time under surgery, one of the potentials for them coughing when they wake up is because this acid in their stomach. So you want that smooth wake up, and they have this GERD. You want to consider giving something prophylactically to that situation. See, tie this into another aspect of your anesthetic. Yeah.
So this may be a silly question. A group of us were studying yesterday. What differentiates Mendelssohn's just from like an aspiration event? Like how? An same?
The syndrome is more when you get the inflammatory response.
Okay.
So you get your fluffy pulmonary infiltrates on X-ray. You know, they're starting to, their sats are decreased because that inflammatory response is impeding your gas exchange. Some aspiration, people aspirate all the time.
Right, and I
at home,
never
and they don't. And you take an X-ray, you do all this, and they're fine.
Okay.
That's okay. I mean, it happens. But the true Mendelssohn syndrome is when they have that inflammatory process.
Thank you.
So again, here's some of your kind of reduced. We talked about that. We talked about your H2 blockers versus your. So the biggest thing here, and this is probably a board question too, is you definitely want your non-particulate antacids. Non-particulate. Okay. So because those will actually become not necessarily a foreign body, but that themselves can be a risk factor for that chemical process. When you have somebody that has an increased risk for aspiration, and you want to protect them from that, you choose endotracheal tube, you choose an LMA. You know, length of case doesn't really matter between LMA and endotracheal tube. It's the patient themselves. So if they've got a real bad incidence of GERD, you may want to choose on the, you know, on the endotracheal side. But let's say you have a, what would I say there? No, I would choose the endotracheal tube. I was going to say somebody that has potential for a difficult airway versus aspiration. And I think if you plan well enough, even if they have a difficult airway, let's say they started aspirating on LMA and they have no difficult airway, you're probably not going to be prepared to that situation. So, yeah.
What would be a scenario where you would actively decide to use an LMA over an ETT tube?
If you didn't have any airway adjuncts. What are you talking about for a full case?
For a full case. It just seems like, why not intubate everyone?
Well, because there's higher incidence of trauma with intubation.
But when you think about potential for aspiration, like you hear about cases where they don't have any, you don't have any indications that they're going to aspirate, but then they aspirate anyway.
You can't help that. But then, if you're going to intubate everybody, now they're going to have incidents of potential damage, potential foreign body.
Okay.
You know, there's been some people that they nick the, what do you call it? Not piriformis. Hang on a second. Anyway, there's an artery back there that, you know, if you crank down a little too much, you get a little squirter, and now you're in a difficult situation. Your airway's filling up with blood and all this. So I think the least potential for harm is what you're looking for.
Okay.
So you're doing a podiatry case, and the patient doesn't have any GERD. I think you have a higher potential for dental or airway trauma from an intubation versus a blind LMA. You know, every patient's going to dictate something different. That's where you're going to come in. You're going to be the expert, right? So you're going to make that decision. So yes, maybe other people, there has been some aspiration or whatnot, but what was the case? What was the circumstances surrounding that? And I use LMAs in high regard because for me, especially at a surgery center, they're a quick backup. I do a lot of cases where they're doing facial oculoplastics or just facial surgery, and you're sharing the airway per se. So don't LMA everybody. You know, we'll put a nasal trumpet in, oral airway. That's an unprotected airway. You know, they can potentially aspirate on that as well. But just know that you either have to intubate quickly, or if they lose the airway, whether it's an obstruction, you can put an LMA in quickly. Have your backups, your plan A, B, and C ready. All right, that's going to be your job to know what are the risks versus the benefit. What's the ratio there? So you can prepare to defend your court if you make the wrong decision. I don't know if that answers your question.
Yeah, thank you.
All right. Rapid sequence intubation versus awake intubation. How are we going to do a rapid sequence? They have a traumatic patient coming up from the ER. You're going to get them off to sleep. What are you going to use?
Sucks and propofol.
So both people use what? Succinylcholine?
Yeah.
All right. Hopefully in the reverse order. Now with some Gamadex, some people will just knock them out with rocuronium or bacteronium, and then they'll get back with Gamadex. Use etomidate if you need to, if it's a hypotensive trauma patient. So, but if you have time, you have in the difficult airway, you may want to consider a fiber optic awake intubation or a nasal intubation where you can kind of numb the airway up. I think airway blocks have fallen out of favor. I haven't done one probably 6-7 years, but I hope you guys have the opportunity to learn airway block. They're kind of fun. They're not too difficult either. You learn the anatomy. and they're pretty simple. And I hope that you get the opportunity. And I would, if you have that potential for a wake intubation, learn, press, beforehand, if you go over the situation with your staff member the night before, and you're like, hey, yeah, maybe we'll do a wake fiber optic, and you're like, cool, I'm gonna learn all the airway blocks, maybe we can do them. And if your staff isn't comfortable, maybe if you're with an attending that is, you ask your attending, hey, what do you think about this? Let's do this. So a transtracheal or a SLN block or whatever, they're really cool. All right, this is a slide, I put this in here just recently, actually this morning. So when I was reading this came from some article from Canada. And I thought this was great because it kind of really ties everything together in these separate portions. So the first part is you see, and if you can remember these in your head, it kind of gives you everything. Now, you may not be doing a cricothyrotomy, but at least you can remember the lemon, the rod, the bone, the short, and then it kind of resonates in your head what all I need to look at. I'm pretty sure this is probably not going to be on your test since I just put it in this morning, but I really think you should know this. This will help you out in the field, in OR or whatnot. Again, we looked at the lemon scoring that you can relook at and kind of commit that to memory. We talked about bagging somebody. We talked about the beard, the obstruction, the neck stiffness, potential masses. Pregnancy. What would make somebody that's pregnant, what would make it difficult to bag or even intubate? If they're already kind of large to begin with, they're going to have even more airway swelling. That's just a natural phenomenon with pregnancy. Right? I mean, that extra volume has to go somewhere, right? So usually the airway will swell a little bit. Now, that's kind of massive. What about intubating when we get pregnant? This was happened to me recently. So
soft tissue.
it was kind of an emergent situation. Anytime you're going to intubate somebody that's pregnant, it's more emergent for the baby than for the mom. Had a lady, she had extremely large breasts, and they were engorged. So we laid her flat, and literally they were right here, all around her chin. And we had really nowhere to maneuver laryngoscope. We even had a short handle, it just wouldn't work. Took the blade off, inserted it, tried to hook the handle back on, still wouldn't do anything. So we had to use a McGrath and intubator, but that's one of the biggest issues. I mean, we even had her in almost a reverse Trendelenburg. So it's, their pregnancy, that can be pretty serious. Because now you have two patients to kind of worry about. You have to get them intubated pretty quickly. We talked about stridor, airway obstruction, OSA, things like that. And then your LMAs. So here's kind of an answer to your question about intubating versus the LMA. So this would be a way to assess that up front. And of course, if you're considering a cricothyrotomy, this would be it. Now, here's a question for you. You have a patient coming in with a submental abscess. How do you proceed? Bless you. What would think in your mind? How would you do this airway? Would you do an LMA? No, neither would I.
I would have fiber optics and scope available and extra staff. And we should be ready to do it right.
I don't think you need it right, but I think your biggest worry is splicing the, or somehow turning into the abscess, and then now you have all this extra contacts. So if it's a controlled situation, I'd probably use a glide scope or some type of fiber optic means, because I had this with a student, and it was a small abscess, wasn't a big deal. But when she went to go insert the tube, she wasn't watching where the tube was going, she was watching the cords, which teach you always, don't take your eyes off the cords, don't take your eyes off the cords. But she did what she was supposed to do from what we were teaching her, but she also didn't know, she didn't look where she could pass the tube. So, and so she nicked it. But luckily, she got the airway pretty quickly. So, but put the patient on a few more antibiotics, and that was that. And then they watched for any potential Mendelssohn syndrome type. But it's real, so you have to watch both in that situation. You could do fiber optic scope, a little potential for less trauma, but it may be a little bit more difficult as you're learning. But you really, really need to look where your tube is going first as you get it into place, and then look at the ports, which I think the fiber optic or advice scope type will be the option. Here's assessing airway obstruction, kind of a stepwise process. Go ahead.
mentioned the graph.
Yeah.
Different kind of.
It's it's kind of like a gyroscope. It doesn't have a cord or anything. It looks literally it looks like a laryngoscope with the little TV on top.
Okay.
So, and we have an OB now, and they're the ones. They're absolutely awesome. They're lightweight. Boom! It helped us out because we were able to. It was smaller. It was more compact than our regular laryngoscope with a small handle, and it worked out beautifully. So. And getting cheaper. They get even more cheaper for one in every room. But the glide scope, you got to keep it plugged in or whatnot. At least this here, you don't. You just have to make sure the batteries are changed out. That's not really available. So,
Maybe the iPhone X will have a Bluetooth.
so you say that there is actually a company that makes a. I don't know when the Bluetooth version is coming out, but it's. Oh, what is it called? Vivid Track is what it's called, and they're supposed to be Bluetoothing into your phone. So you have this little tiny handle, same thing, and Bluetooth straight to your phone. Otherwise, now you can hook it up to your computer and do the same thing. It's a heck of a lot cheaper. The blades are disposable; they're like $80 a blade. So if you have your phone, you boom, done. So now you have this cool device that's a lot cheaper. But I'm pretty sure it'll have some limitations.
I want to put it on your watch, your Apple Watch.
Yeah. Until you get a phone call, you're like, oh man, why did you call me this time? Patient died and now you're through. Yeah. So, yeah, how are you going to explain that? Well, I had the airway, but then smoke called me and So anyway, assessing airway obstruction, this is pretty good little slide. Again, this is one too. From the same, I should have cited the article. I did not. I apologize. NAPA. But it was a Canadian article, and it was pretty good. It was like their EMS, but their EMS, they have physicians that go out to the EMS, so it was geared towards them. But are they? So again, is there airway obstruction due to because they're obtunded, the tongue's just falling back of the airway? Is there a true foreign body in the airway? What's the stridor coming from? You don't know. Is it some type of swelling, epiglottitis, which is fairly true emergency? We had one come to the ER. The ER physician wanted me to assess the patient and let me know what I thought. I see the patient, a larger individual, big neck, somebody that I would kind of like take 2 or 3 looks at before on a regular normal surgery. Now you put epiglottitis on top of that, and I just look at the ER guy, like, and he's drooling already, he's flushed red, and he's been sitting there, I don't know how long, and he can barely talk. I say, you gotta get him to the OR now. Have you called ENT? Whatnot? At least they called ENT, so they were waiting for ENT to see the patient in the ER. I'm like, this is ridiculous. You need to get him up now. So I called. Where I work, we were actually hospital employees, and then we kind of work in conjunction with the the MDs, the anesthesiologists, there's that same thing with Riverside. So I called the attending desk over the OR that day, and like, hey, this guy's got to come to the OR now. I'm not going to touch him in here until he passes out, but even then, you're going to need to do a preg. So she came down and she took a look, and she was like, we gotta go now. But ENT wasn't available. Luckily, they came in after that and they got him up to the OR pretty quickly. But again, these are scenarios that you're going to be placed in. And, whenever you're finished, it can be pretty quickly if you're the only one on call that day or whatnot. So, what are you going to do? And that's the purpose of this. All right. This is a pet peeve because when I was in, as an RT, I knew this frontwards, backwards, but when I go to the PACU and you see some of these ridiculous names, like you would see them on a simple mask and they were placed on like 2-3 liters. I'm like, great. So now my CO2 is going up, they're gonna get uptunded, I'm gonna get blamed for giving too many narcs. Like, no, so I don't know if they're gonna put this on the test or not, but it's in here for your information. Please never put anybody on a mask lower than 5 liters per minute of O2, or else you're not gonna wash out their oxygen. Nowadays, there's no such thing as a non-rebreather because almost all manufacturers take out that extra one-way valve as a safety precaution because people were being left in the emergency department on tanks, and the tanks would run out, and then every time they suck in, they barely had a seal around here, or they had a decent seal, and they were becoming uptunded and coated because they were rebreathing their own CO2. All right, how are you going to manipulate the head, y'all, for an airway? So recently had a student, and we're doing egg retrieval. So there's 2 ways that we normally do egg retrievals at surgery. Is we can do them by nasal cannula and still get propofol, or we can use a mask. And if they need to, if they get a little too much, then they can mask the patient back, no big deal. Which is good because then I think we had 5 eggs and it was all counted for mask cases, which you're going to need. So come see us at the surgery center, you'll get your mask cases. And I saw him looking, just standing back, and I see the patient, and I'm like, she's breathing, but doesn't really have airway. You don't see any fogging in the mask. You don't see any end-tidal CO2 on the monitor. So how's it going? Snaps are good. All right. Patient breathing? Yeah, patient's breathing. Okay. Do you have an airway? Yeah, I have an airway. Okay. So I have sets. Now are like 99, 7. Okay, let's just barely lift the chin. And all of a sudden, I guess she didn't have an airway. It's a fine line between obstruction and non-obstruction. So, and I showed her another technique where you can really get that tongue. That tongue will stick to the back of the throat. It makes it a little bit more difficult. So there's different things that you can do. As long as they don't have any major TMJ, you can just kind of push that jaw up and hold it over where the bottom, the mandible is almost above the maxilla, or the incisors switch. And she barely had to hold the jaw at that point in time. So it was real nice. But there's that fine line, and I can't stress to you enough, which I did to her. I said, look for all the signs. Don't worry about the monitor. You can see everything you need to from the patient. Even if the CO2 is on the monitor, sometimes it's not the end all be all. Like for instance, our nasal cannulas have CO2 applications with them, but sometimes that sucks up against their nerve. You don't see CO2, but they're breathing quite well. And sometimes it's true, they're not. They're obstructed. So look at everything. And the first thing you look for, are they actually breathing? And if they are breathing, that's good. That's number one. You didn't give them too much. And secondly, can you feel? When I used to take my patients to recovery, I would hold my hand over their mouth if I didn't have anything on. If I could feel them breathing, I know they have a paved airway. That's pretty simple and easy. That's all you can do. One hand up here, one hand pushing the stretcher. Not a big deal. But you look at their, make sure they're breathing. Are they seesaw breathing? If they are, then chances are they're obstructing a little bit more, so maybe we need an adjunct. But chin lift, let's see, we have a little C. Here's that sniffing position we were talking about. So if you have to put a pillow up underneath, then do it. The EC clamp, please, 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 please don't put your fingers submental and push their airway, make it occlude. Make sure it's on the bone. All right. Now, I guarantee you, every one of you, you're going to do that. You're going to get your hand slapped, even though you're doing the right thing. Because sometimes it looks like that you're really pushing up submental, but you're really on the bone. So don't worry about it. It's going to happen. All right. Just shrug it off your shoulders. Someone's going to hand slap you for that, even though you're doing the right thing. So this one actually looks like he's pushing up into the submental space. It may look better if he's actually on the bone out here, and that's what I'm talking about. All right. Don't hasten the situation. Just another view. I put this one in here because try to keep that mask off the eyes. Otherwise, you may cause some type of corneal abrasion. So be careful. Sometimes what I like to do is I like to put the mask down low and let it fall where it's going to fall. And this will also tell you if you have the right size mask for that particular patient or not. Sometimes you don't have that opportunity to get into the mask. If it's an emergency or whatnot, you don't have that opportunity. Just be cognizant of if they have one eye half open and you're pushing down, that you could cause an issue there. If you didn't tape your eyes shut before, some people will tape them right away before they start masking. And remember, this is what the patient's looking at before they go to sleep, if they remember. Don't let them see you sweat. So again, we just talked about the size of the mask. And most people aren't going to put straps on the mask anymore. That's if you're going to do, unless you're maybe with Dr. McDonough, if you're going to do a hand case for 3 hours. I don't know, a mask case for 3 hours. I don't know if he does that anymore. But all masks have a little 4-prong place so that you can strap the mask to the head if you need to. Just be sure that the straps are not going into their eyes. These are some of the issues here. There's a mask. And what will happen is, most of these masks, they have 2 straps. So sometimes the straps can be in eyes if you're not sure. All right, here are the axes I was talking about. So what you'll see, actually this is kind of your best view of the laryngeal aperture. Now, what sometimes will happen is you have an obese individual that they put, as they lay here, this is the view that you'll see. It's not the best. So you'll actually put some, if you had a, what we have in OB is almost like a wedge. And you put a little bit of height under their head and then barely under their shoulders, and that puts them in this type of view. And I think I have a picture of that. Like that. And you see how their chin and their face is almost parallel with the ceiling. Their chin's not way up here, giving you this angle. This is kind of the angle that you want. I think Nagel had a pretty good chapter on positioning the airway, if I remember correctly. All right, let's talk about oral airways and nasal airways. They come in different shapes and sizes. I think this was a Goodell, and I don't remember the name of that. It's kind of irrelevant. What would be an advantage over an oral airway versus a nasal airway?
Do all their weight.
Correct. Easier insertion as well. If you use a tongue blade, it makes it really easy. There's several different techniques of putting them in. You put them upside down and twist them around, whatnot if you don't have a tongue blade, but generally speaking, if you're going to put a whole airway and just have a tongue blade handy, it makes it so much easier. You're going to measure it correctly. So this is going to be to the corner of the jaw versus a nasal, which will be to the earlobe. And then you want to make sure if you don't have the right size, then A, you're not going to release the obstruction, or B, you're going to cause the obstruction by pushing the tongue further into the airway. Please make sure you have the right size. And here's what I was telling you, you can kind of flip it upside down if you didn't have a tongue refresher. Nasal airways, you would like to have the bevel toward the septum, all right, if you have that opportunity. So basically when you're going to insert an oral or a nasal airway, you want to kind of look, and it's the same thing with a nasal intubation. You want to assess the nair that's larger. Most people have one nair that's larger than the other. You want to make sure there's no type of, like if they tell you, oh, I have nasal polyps or something, or just some kind of funky situation on one side, or if they have a nose ring, probably would be good to put on that side. So, but you want to probably have to take the nose ring out. Anyway, but you want the bevel toward the septum cause least trauma. And there's a way to insert it. These I don't necessarily recommend upside down, as this picture shows, but it also came with this one, which was nice. Now, most people insert it and they hit the back of the skull right here. You kind of want to find that straight down. Once you get around this little curve, it'll go straight down, and that's the way you truly insert it. Not this way. So then you're just going to keep causing trauma. Bless you. And as you see where that bevel is, the bevel's toward the septum there. And that's kind of how you want it. Go ahead. And what's one particular patient that you probably don't want to put a nasal airway in? Ball fracture, what else? Pregnancy. No, yes. LMAs, we're going to kind of breeze through these. LMAs are great. They are a great backup airway. There's different types of LMAs. Classic Pro Seal. There's Superior. What's the newest one? I have it in here. I haven't used it in a while, but it's kind of a combination of all of them. It's great. Again, you have your 1522 millimeter adapter, hooks up to your circuit. Most LMAs you can intubate through if you need to. You have the just straight up aperture bars, and then of course your cup. On the LMA, it'll give you, on the package insert, it'll give you an idea of what patient weight you can use it with, and then it'll give you what's recommended inflation, many mLs to inflate the cup. You'll see a lot of different ways of doing this. Just remember the airway is not protected with an LMA. You just maintain an airway with it. Here's a Pro Seal. So the Pro Seal allows you to throw some type of suction device. It'll fit a OG. You can put it right in there, and it's supposed to go into the stomach if you have correct insertion, because the tip of the LMA rests inside the esophagus. Don't really see much of these. Now, this is a fast track. This intubating LMA is what it's made for. The difference between this is there's an aperture bar that actually elevates, versus the other ones are made in place. But you can still, in theory, intubate through the other ones. This one's a little bit easier. Story time. So I was at Shands doing 24, and I got called to the ER. My attending says, "Hey, can you go down? They have a difficult airway." Sure, I'll go down there. And then I had my trusty sidekick, which happens to be Miss Carol's brother, Jerry, who's awesome by the way, said, I called him, I was like, Jerry, because it's middle of the night, it's like, just bring our different airway back. We go down to, it was actually the trauma center. He was in Halo, and was in an accident. He was also in a rigid collar, and the resident, actually it was the surgical fellow, who tried to intubate multiple times, and I come in and you can see blood coming out of his mouth. Great. But you know something's up when before you get to the patient's bedside, the trauma surgeon meets you and says, hey, kind of gives you a quick lowdown. Good thing, Dr. Burns. So get in there and they're giving them the sucks. They had a glide scope and there's just bloody equipment everywhere. That's fine. So first thing you do, I'm just going to start putting one of these. Like, I want to make sure I can actually bag this guy. So put in one of these and it was easy bag. So I'm like, all right, we're cool. But we got an airway. We have a little bit of time. But I couldn't pass the tube. The way he was sitting was too anterior, didn't put it in a good position, but I knew we were in good situations with the bag, so we had other opportunities. So it's like, fine. So I put that in and bagged them, got them up, came out, used their glide scope, but every time I put the glide scope in, it just bloodied up the camera. And they had one of those glide scopes that had a disposable blade. It's like, all right, well, this ain't gonna work. So they give me a fiber optic scope, so we can do that. So I put this back in and try to go in, same thing, bloodied it up. Like, well, this sucks. So I said, Jerry, go get an arc glide scope, because I already knew that the camera angle was different. The camera angle on the disposable is closer to the end of the blade, whereas ours sits back. So I might get a better view. So Jerry gets ours, and I had a great view, but I couldn't insert the tube. It was still too much of an angle. I said, fine. So I asked the trauma surgeon, say, hey, can you hold the glide scope right here? And then I got the fiber optic scope. I had a great view of the aperture, got the fiber optic scope, and I could see the end of the fiber optic scope through the glide scope camera. So I just manipulated the fiber optic utilizing the glide scope and got the tube. So I had to use everything I could think of at that point in time to get a tube, because they had a halo in place, the rigid collar, and try to get it somewhat quickly because we needed a tube to protect this airway. I couldn't get it with this adjunct, so we made a combination. And had that done and got the airway, trauma surgeon thanked me and whatnot, and it was probably months later, I was talking to this friend up in Maine. He runs the hospital system up there, he's a CRNA. He came down here, went sailing with us, and I told him what I did, and he thought it was cool, so we went back up to Maine, and then he went to a difficult airway course, and guess what, they were teaching that technique. And just kind of, I don't know if they had already doing it. I made this up on the fly because that's all I had. But he's like, he actually called me later on, randomly out of the blue and said, hey, this is what they're teaching in this difficult airway class. I'm like, oh, that's cool. You heard it here first. Know all your equipment, learn it. You never know what you're going to do. And what you got to learn what the advantages and disadvantages of all your stuff is. And be ready to use. Every place is going to have something different. Find out. That should be some of the, when you go to a new clinical facility, know where your MH card is, know where your ICE is at, know all your difficult airway stuff. Hands down, those are the 3 things you should know right away. And then for JACO, where are the extinguishers, all that. What is that? It's a Supreme LMA. It's another one, it looks like this. It's a disposable, it does not have a handle, but it already has a curve in it, and it also has your port that you can stick the suction down. Those are pretty good, and it has a kind of a black block built into it. So those are those Supreme, very nice outfit. This is just kind of how you use it in fitting LMA. You kind of use the handle to lift up if you need to. And it's a blind insertion, so you're kind of lifting up, doing all this stuff. They should teach you a little bit of this in the advanced airway. There's so many adjuncts now. That's probably a 3-4 hour course if you really wanted to. Again, this is, you'll see all this on the packages. Tells you how much volume. In my opinion, I use less volume now than I did before. Excuse me. And I kind of, most females I use a 4, most males I use a 5. Smaller males I'll use a 4. Or even small females or even kids I'll use a 3. It's kind of what I do. And it works out quite well. Usually don't have as much leaking, or the seal is not broken. And I use, when I insert it, I actually insert it using the ambient air in the cup. I don't take any air out of the cup. Whatever's in there from the factory is what I use. And then I only put maybe 5 cc's in the cup. If it works really well, I'll put 10. I think what I have seen before in my, this is just me in my practice, is that when I would put more than 5 or up to 10, I think it distorts more of the cuff, it pushes it out, and then you get less of the seal. That's me personally. I think as you keep going through your practice, as you learn this stuff, you'll see different techniques that work for you and what most of the time will work for your patients. Of course, you're gonna inspect it. You're gonna make sure there's no, even if you open it up, you are gonna test to make sure that the seal is patent. You can put a little bit of some type of lubrication on the outside of the LMA. Hopefully when you do your first insertion, what I mean by the outside, let's go back to.
I've seen some do it only on the bottom, and I've seen others do it on both.
Yeah, you know, I'll have saliva. Just put it on the back side. What I normally do is I put it on the back side. When I put it in, I try to, you hold it kind of like a pencil. And this actually came from Dr. Brain, who's the one who created LMA. Is that if you kind of put your finger in here when you're inserting it, it's a guide. You kind of want to push it up against the hard soft palate as you're kind of placing it. And that, if you do that way, then you don't really need any type of lubrication on the actual balloon part. Just a little bit on the outside. And you really don't want, what's the pressure needed to overcome the closing of the lower esophageal sphincter? Anybody know? What's that?
25.
25. So you, in your mind, you keep your pressure, even if you're bagging a patient, or if you have an LMA in, you keep it 20 or below, then you're less likely to push any air in the stomach, right? So another question to answer you is, if you think it's going to be tough to keep the patient, like let's just say you had to give them some type of positive pressure while they have the LMA in. Maybe they have some type of pulmonary disease, pulmonary fibrosis, sarcoidosis, or something like that, that's going to make them rigid. And if you have to give them a breath, or 2 or 3 or whatnot, and you're not going to have them spontaneously ventilating, then maybe that LMA is not appropriate. That would be another scenario. You definitely, LMAs, I put, when I insert an LMA, I'll go ahead and get them deep up front. I'll put them on pressure control, keep my pressure, whatever, 15 to 18, whatever I can get a decent volume on. And then until I'm done with everything, and then I'll get them back breathing. It's just something I do. Other people, they'll just leave it and get them back breathing right away. And when you're by yourself and you're doing a whole bunch of stuff, you just need extra hands. So there's many ways to skin the cat. As long as your patient's safe all the time, that's kind of something you should adopt. But yes, you can put a patient on a ventilator with an LMA. They do it in Europe all the time. They even do it in prone cases. I particularly don't like to do prone LMA. Just me. I think, how are you going to get an airway right away? I know a lot of people do. Just not my thing. I prefer to have a good, strong, dependable intrachea tube. And if you tape it in correctly, the intrachea tube is not going to move when you position the patient. So, inserting it, you'll learn how to do it. That's not the point of this particular lecture. Putting it in, Make sure you have a bite block, just like an intratracheal tube. Yes, the LMAs are probably a little hardy, but you want to have a bite block in it. You don't want to bite down. Because if you have a good seal, you can have potential for negative pressure pulmonary edema. And when you put a bite block in it, it's a soft bite block, which you most likely will have with a LMA. Make sure it's between the molars, all right? Because that's where, if it's just right here, these incisors, they'll bite through those. If you put in the molars, they're going to punch down on those, and if you have a good bite block, they're not going to bite through your tubes. Maintenance, you don't have to worry about maintenance of the LMAs because they're all disposable now, unless you're at a rural facility that likes to reuse LMAs, which you can, they do have those. And then emergence, how are you going to take the LMA out? There's 2 times you can take it out, right? Either wide awake, you say, hey, open your mouth, take it out, or you're going to do it when they're asleep. Now, I've seen some people, they take it out of the LMA when they pull it out. Not my thing, I like to use it as a squeegee and try to pull all the secretions out at the same time. You can suction close, before you pull the LMA out. Just have your suction in hand, because if you're going to squeegee it, it'll all come out and you can just suction it right then and there. It's probably going to be you on your first attempt. All right, we talked about the Miller and Mack blades. We're going to kind of speed up now, get this done. There's multiple types of endotracheal tubes. And I highly recommend, YouTube's a phenomenal accessory tool for learning. You can see all these things. And does anybody know what the RAE stands for in an oral array?
The last names of the inventors.
Yes. The last names of the inventors. Some people say right angle endotracheal tube. But that's not really that. Standard equipment. What's the Murphy side for?
Occlusion diaphragm.
Yeah, or just any extra occlusion. So if your beveled end's occluded, you have a secondary means to get it. One thing to consider with EP tubes that's coming back from the old respiratory days, you get a patient from the ICU or somewhere, and you put them on the vent. If there's a way of potential, you're probably doing them a service if you actually change the tube out. Consider it. Just think about it. You can use a tube exchanger. I guarantee you, if they've been in there for a long period of time, they're probably half the diameter of what EP tubes should be. And we've done that multiple times, especially at Shands. They don't change them out on the floor that I can ever remember. So if the patient's stable enough, stick a tube exchanger in there, pull it out, put a new one in, and all of a sudden your peak pressures are a lot lower. And man, this is great because there's so much crap in there. No fault of theirs. It's just, we're in a controlled environment here. We have all of our adjuncts readily available, and something to think about in the back of your mind. You may want to consider just exchanging that out. So here are your oral rays and your nasal tubes. You're doing ENT, you may want to just ask the surgeon. If they're just doing tonsils, they'll say, hey, an oral tube's fine. Use one of these. It comes straight out here, so it keeps it kind of out of the way. If you're doing some dental work, they may want a nasal. Usually, if you just ask the surgeon, if you never worked with them before, they'll tell you what they want. So you can just plan it accordingly.
What's the rule for checking the balloon prior to intubation? The reason why I ask is the last place that I worked, they changed, in the last 5 years that I was working there, they changed from always checking the balloon and then they never checked the balloon.
Always check the balloon.
So I'm not sure why.
You don't have to crank it all the way up. You're just 8 cc.
So it's still in favor of checking.
I haven't seen any literature to support not checking. Put it that way. You never know. I mean, there'll be times that you check it, you put a tube in, and you're like, it's not holding a seal. Or, you put them in a volume control, and you put in, let's just say you have them on 500 cc, so tidal volume, you're only getting like 300 back. And yet you don't hear great sound, compressed sound either way. And then you may have ripped it on the tube, because guess what? You're looking at the window aperture. And then when you insert it, grab the tube, and it now it pierces your balloon. Again, I have not seen any literature to support not checking it. I think it's a good habit to do it. I don't see any reason not to do it. I do it, I do it on the LMAs. Just pop it, just put a CC or two, because these already have air in it. But again, these are kind of mostly your tubes here. You have your your wire reinforced tube. These are your ones that if you're going to be in a real long neuro case, or maybe it's prone or something, you may want to consider one of these. As the air or the volume in the vent warms the tube up, it's a lot more pliable, and you have more potential for kinking the tube. So it was a long time ago, I think it was ACLS or something, there was a mnemonic that I used, so if I had an issue, my peak pressures were going up, or I didn't know if the airway was going on, it was DOPE. So it's displacement or dislodgement, obstruction, P is either pneumo or PE, and then E is equipment. So that's kind of what I thought right away. So first, you take the patient off the ventilator and you bag them. Are they baggable? If you're able to see chest rise or whatnot, are you getting end-tidal CO2? The next thing I would do is I would suction them out right away with the intratracheal tube suction. That will help determine whether or not secretions or your airway is kinked off if you can't pass the suction catheter. So that's you do quick. Now PE and a pneumo is kind of like way down the list, but it's part of the mnemonic. Then check your equipment. Go from the patient and work your way back. So first check the tube, then look at your circuit, make sure your valves aren't sticking. Is the ventilator messed up? If you're able to bag, that'll tell you a lot more, and that's right off the bat. But you're going to check your way all the way back to your machine. So and rule out machine lapse. So it kind of helps you take all the zebras out of the situation, so you can rectify it quickly before there's some type of disaster. Now, to conclude from the kinking of the airway tube, if you had that long case, this is something you may want to consider, if you have them available. Your high-low tubes give you the ability to suction above the cuff. If you have a patient that's going to go to the ICU, you already know that after the fact or before the surgery starts, you may want to consider just putting one of these in up front. That way, just kind of you're helping your ICU friends out. Anytime you're doing any type of lasering in the airway, you want to have a better tube. We did I did a study with some students that did airway fires and different tubes, and in their study, it didn't matter if the oxygen was 100% or if it was only 21% room air. As soon as the laser touched the tube, poof, it went up. So if you're going to do a laser, please be careful. Make sure you have the right tube. These are the Robichaud tubes. They'll use this in one-lung ventilation. This is more of an advanced airway technique. So it's kind of a special way that once you put it in, that you have to test it between which balloon, and then you use a fiber optic scope to help determine placement if you want to know one side versus the other. But that'll be during your thoracotomies and things like that. So that'll be fun once you get to manipulate the fiber optic scope and get your hands on that. These are NIMS tubes. They're muscular monitoring tubes. So if you're gonna, more of the ENT surgeons nowadays are using these when they're doing thyroidectomies. they'll put this in, and you basically want your vocal cords in between the blue lines, and then as they're making incisions, it's getting, or if they're using Bovie or anything else, if they're getting close to a nerve, it'll sound on the machine. So if you're doing that type of case with thyroidectomy, just ask the surgeon, hey, do you want a NIMS tube or one of the neuromonitoring tubes? If they're old school, they'll say, nah, we don't need that. Here again, here's your internal diameter. That's what's reflective of the size of the tube. You know, your average female is a 7, your average male is 7.5 to an 8. Another rule of thumb, if they're going to be in the ICU for a long time, I try to put a big fat tube in if I can. Helps them out because we know that as the longer their stay is, the more secretions and stuff that's going to be around the inside of the tube. And the other rule of thumb is if you pick the tube correctly, then you just multiply the internal diameter by 3, and that's probably your safest insertion number. So for instance, this is a 6, and if it was the right size tube for the patient, then it would probably be about 18 at the lips or the teeth, depth-wise. Just a something I pulled off one of the in the books. Of course, you hope that you have these 2 little lines here. You hope that that's where your vocal cords are going to sit right between there. Now, there's something. Have you guys heard of allotment? All right, so you insert the tube right here in your suprasternal notch. You take the pilot balloon, push on it. You should feel that right here. All right. Where are your vocal cords? They're higher than that, right? So therefore, if your balloon's right here, then it should be a good depth. If you don't feel that, I mean, obviously you're going to listen to them. Some people say listen to your stomach first. You know, really, you can check your CO2, whether it's capnograph or it's on the monitor. You're going to listen to your lungs. If you're feeling frisky, listen to the stomach. Hopefully you don't hear anything. And then you can do for a quick down and dirty, if for whatever reason you're super busy, but we do it anyway, every day, we'll do allotment, and it works every time. So just another way. Some people may look at you like, what are you doing? I'm just checking your teeth placement. The theory sound, it works every time. Talk about some tricky intubations, why you would do it. If they're obtunded, if they're compromised in any way, if they're bleeding, you want to protect the airway, if they have GERD, things like that. You don't necessarily need it on procedures of the head and neck. I'd say I've done rhinoplasties with an oral airway, works just fine as long as the surgeon suctions out whenever you hear something. Whenever we get our, been talking to McDonough about to get our rotation back with the Garcia, or Dr. Garcia, at his office, so some office-based anesthesia. We'll do rhinoplasties there with an oral airway, but you will have your earpiece in, listening to the patient the whole time. Whenever you hear signs and symptoms of either blood or something in the airway, you will ask the surgeon, hey, can you suction the patient out? And as you do, he'll suction them out. And it's a wonderful thing. You'll be able to do a rhinoplasty with just an airway. It's pretty cool. And the patient will be absolutely fine. Been working with the same guy for 9 years and had no major issues. Done 9,000 cases out there between not just me, but all of us, and been absolutely fine. So that's our next goal. We got you guys at the surgery center, and then we'll get that set up, and then you'll get to rotate between all of them. So again, if you have to do any long-term controlled ventilation, or if you have that patient that has some type of lung disease process, whether it's pulmonary fibrosis, sarcoidosis, or anything like that, you probably want to intubate them versus elevate. Again, some more, okay. This is a pediatric airway, but nonetheless, what you don't want to see, it's nice if you can see the esophagus here and your laryngeal aperture. your vocal cords at the same time, because then you definitely know where to go. See the one on the left, a little bit swollen there. Be very careful when you're inserting that. And then the other one, you can see the rings. This is what I hope you all see on your first intubation. You can even see the rings back there. And if you still miss it, oh my goodness, you may live to see another day. Again, we're talking about confirmation of tube, whether it's a capnograph, or you have it on your monitor, listening, we talked about all that. Know if you're in the esophagus. First couple breaths, you may get a little CO2, but if it has this deep shindo motion, you're definitely in the esophagus. There has been some studies that show that there's a little CO2 if you're in the stomach right away. You'll see some on your monitor, but it starts higher real quick. It's like 1 to 2 breaths. Don't get fooled. Make sure you see 3, 4, 5 breaths before you get true confirmation if it's in the airway. Peak pressures are going up. Not seeing any CO2. Listen over the stomach. Sometimes you don't hear over the stomach right away because it's already blown up if you mask them and their stomach's way out here. You may not hear that over the stomach. So again, listen to your lungs, allotment, CO2. On your monitors, look for all these things. We talked about negative pressure pulmonary edema. We talked about lighting tube on fire, sore throat. 20-30% of patients normally get a sore throat after intubations. Your first shot, by 50-60% of patients will have a sore throat. It happens. You're learning, it'll happen. Try to prevent laryngospasm. You know, nowadays with the decrease of narcotics, I think narcotics really help with the reduction of laryngospasm when they're waking up. Now people are doing less narcotic, so I think, my opinion, if you don't do this correctly, you're going to have an increase in laryngospasm. Just my opinion, but we'll watch. But if you do it correctly, you're not going to ever have laryngospasm, right? Then you get this croupy cough potentially afterwards. You get this stridor, some upper airway swelling. Everybody know what you would give for that? Racemic epinephrine by Deb. So you can give that in the recovery. If it's a croup, don't give them albuterol, it's not going to work. So you got to decipher if it's stridor or bronchospasm, and that's what you're going to have to listen. So. I think we talked about this extubation criteria here. If you're going to do it wide awake, then you can have them lift up there. If they're making purposeful movement, if you've given them paralytics, then you're going to make sure they're strong enough. Make sure they can pull, if they can pull a large enough volume. Is one big thing. About 3 mLs per kilo. I'm not 3 mLs per kilo. Sorry, that's BC. But normally between 500-600 on average volume. That's pretty good for most adults. And you're gonna do your trainer 4 with Gamadex. It's really revolutionized this. Makes it much easier to reverse a non-polarizer, and less likely to have somebody that is still pretty weak from a paralytic. I don't really do the hand grips, but if you're ever worried about extubating a patient, you don't think they're strong enough, then don't extubate them. All right, call your staff, give them a little something to relax down. Wait, that's fine. You don't have to be that fast, because if you extubate them, they're weak, and you go back to re-intubate them for whatever reason you can't get the tube, you're going to be in court of law. Morgan and say, hey, why'd you pull that tube? Like, oh, I thought they were strong enough, and they weren't, and you have nothing to stand on. Suction them up ahead of time, reduce your incidence of laryngospasm. Know this, frontwards and backwards is changing as we get more adjuncts. The quick and dirty is mask them, can't mask them, try to intubate, can't do that. You could try other adjuncts first, whether it's a fiber optic or a glide scope. Don't forget about your handy LMA. It works wonders as a backup, like a quick backup if you can't mask them. So don't forget about your two-hand technique. Have a buddy to back for you. But literally just go through this in advanced airway. They'll go through this, work with you. But it's here, look at it. Things to come. There's multiple blades. We talked about 2 of them. There's a fiber optic scope. Light one's pretty cool. Hope you get the opportunity to do that. It's a blind insertion technique. Turn on all the lights. You insert. You have a tube on the end of a light, or light at the end of the tube. You insert it, and you really look for it to light up. And it's just kind of a rocking motion. Like I said, blind. Once you have some give, put the tube in and see if you're there. Either going to be one or 2 places. Hopefully, you got a opportunity to get in the right spot. Never really see the bullet scope anymore. Of course, the LMA you're going to use as a different airway adjunct. There's some intubating stylets. Don't really use them too much. They do have some at UF, I know for sure. You don't see a retrograde intubation kit anymore. Rarely ever used. You will use a bougie if you need to. Again, look at all these things. I've done a transtracheal jet ventilation in a long time. I knew the one at UF was broken for probably about 6 years. Combi tube, you'll see that maybe if somebody comes up from the ER, use it in EMS. You don't have them, generally most people don't have them anymore. Again, think yourself, what would you do? Hopefully very soon, this will be you guys. All right, questions?
The intubating the LMA, does that actual LMA part stay in while you pass the tube?
So yes, you'll pass the tube. And then there's a stylet that you put on the end of the tube. And all right, so there's a stylet here. So this part stays in. You insert the tube. As soon as you get it, you'll have to pop off your adapter, and then you put the stylet in there. And it's almost kind of like an epidural in a sense, where you're sliding the LMA out as you're holding that adapter still, so the tube doesn't move. And once you get close enough, you'll be able to grab the tube below, right here, and just pull that out. But there's really no reason. If it was truly that difficult, just leave it. And then eventually what you can do is put a tube exchanger in and take it all out together. And then put a regular ET tube in. YouTube it, it'll show you back how to do it.
Okay.
2 slides forward on that mass size chart
The
for the LMAs.
for the LMAs? Oh, you said 4.
Maybe that's 3, 4, 5.
Yeah. The gray chart. There's a max ET tube. Is that internal diameter on the phone right?
Correct.
Is that just straight for, is that the size that is required to pass through the LMA, or is that just the recommended size for that patient size?
So if you had a size 6 LMA, you can put a size 3 ET tube, like diameter wise. It's just saying that you can't go any bigger than a 7. So you can't put a 7.5 or an 8. It won't go that well.
Okay.
So that's all. That's Now remember, these are different in the fact that you are going through static aperture bars. They don't move. They may kind of bend, but the intubating LMA has a bar that lifts up. And what it does, when you go through it, it lifts the epiglottis out of the way. But these bars do not. So that's why you're really going through the little bars. show us. That's not a great picture, but right here are two aperture bars that sit like this. And it's prevent the epiglottis from getting into the airway itself. Other questions? You guys are all ready, huh?
This is great, thank you.
You mentioned sore throats. I know you work at an outpatient surgery center. Are there any adjuncts we can use to prevent that? There's no.
Good technique,
Okay.
pretty much. Not really. So you can give them, you can squirt a little lidocaine or whatever, do any of that stuff. Some people, long cases, would put lidocaine in a cup, an ET tube, and over time it would go around the actual cords and whatnot. That's on a long case, and it's more theory. I haven't seen a LTA in a long time, where you can kind of inject the cords as you're, basically you do a laryngoscope, do the LTA, and then put the tube in. It doesn't really matter. It's more your technique. And honestly, as a student, you're going to be a little more abrasive to the airway. Then as you get better, you do more, you're going to be less abrasive to the airway. So, but even now, I think LMAs now cause more of a sore throat, especially in the outpatient center, than an actual endotracheal tube, if you do it properly. But that's just my understanding, just talking to patients afterwards and seeing, like, oh yeah, it's sore. But we tell them up front, 20-30% of you are going to have sore throat. So usually it's not a big deal.
I forgot, what does LTA stand for? Something that Tom
No.
lidocaine.
Yeah, it's
Atomizer?
local insect.
Local.
I don't know, it's one of those. You got me.
So it looks like a old school female, like the perfume. That's what you're talking about, right? Where they have the stylet that, you know, and then they put the atomizer on the end, and then they.
Well, all the ones I've seen have, has like a,
Yeah, like, yeah. It's a cheese.
then you have your local anesthetic right in here. And all it does is it just kind of sprays out here. That's it. It's like a stylet almost. Yeah.
For children, I think I read that you normally use the Miller's weight.
Yeah, I mean, like I said, whatever you work with, they're slightly more anterior. It's easier to directly lift the epiglottis with the child. But again, if you have a Down kid, personally, I switched over to a Mac blade for a Down kid because they have a lot bigger tongue. For neonates, for sure, straight blade, they don't even make Mac blades that small. You're going to use a 00 to a 0 on those blades. But most of the time on a child, use a straight blade.
And I was reading that like their epiglottis is more fragile. So what do you do? Like, what does that mean exactly? Like, what does it mean if you damage it? How would you prevent that?
Well, it's literally, you don't need to crank up. I mean, they're fragile heads. You have a lot more strength in your hands, and you're a lot heavier, or you have a lot more, literally, you don't need to hold it weight like this for a kid, or even a neonate. You can just literally hold it with your 2 fingers and pull up, and it's right there. Most of the time they're anterior. You're not going to do anything special, just be very, very careful. And what I normally would do is I would follow the base of the tongue. So as you're going in, they don't have any teeth. I'm talking about more like the neonates and babies. You're just going to follow the tongue until you see the epiglottis, and then once you see the epiglottis, you're just going to swing up under it and then barely pull up. And that takes practice. I thought neonates were a lot harder at making than adult. Most people get puckered up, which is normal. And but I really do think they're a little harder. But if you just calm down, take a few deep breaths, just literally, you just do a very simple follow the base of the tongue. Now you know where you're at, because their airway is a little bit different. I mean, seriously, their airway looks much like an adult's epiglottis or esophagus. I guess it's just you don't necessarily see those structures well enough. It looks just like a hole. And so hopefully it's not the esophagus. Now, the other thing to consider with a neonatal baby, it's really easy to dislodge that tube. So 1 millimeter and you're either main stemmed or you're not. 1 millimeter, you're out or you're not. So you have to be very careful with that. And then, of course, don't get too aggressive in the back. On a neonate, all you really want to do is some chest rise. It's better than looking at the vent, looking at your tidal volumes. Don't even look at that. You want to see chest rise from here to here on one of those kids. And that'll tell you all that you really need to know. Especially if you put them on most of them were uncuffed tubes. You put them on pressure control. You never put them on volume control because it's going to give you a set volume. Half of it will leak out of the tube. So you don't know what you're giving. So put them on pressure control and it'll keep giving you volume until that pressure is reached. So some of it will leak out. But if you look at them and you see adequate chest rise, that's going to help you out more than anything else. All right, anything else? Yeah.
So is it more common to use a low pressure, high volume cuff in these anesthesia cases? And what's the indication for a high pressure, low volume cuff?
Most of them are high pressure, low volume. The ones that are low pressure are the ones that have the foam inside of it. Have you seen those? The true low pressure are, the volume is, there's some foam inside the cup, and that is what's kind of make the seal versus the actual pressure of the balloon itself. If you have high pressure, theoretically over 2 hours, you're going to start to frozen the tissue. You're going to impede the blood flow to the tissue, which is where the cup is around. So this is kind of the reason why people go to trach after 2 weeks or whatnot to help prevent stenosis of the airway, things like that. But normally on an average case, no. If they're going to be ventilated for a long time, they're going to go to ICU. At that point in time, they're going to make a decision to either keep that tube or change it out. If you have those available, usually in OR you don't have those available. They're more on the ICU side. So, there was a question.
I've always heard them say when they put in an element to listen for the pop. What would cause that?
I don't know. Usually in the LMA, when you put it in, you'll feel it go around the curve, and then whenever you inject some air into the cup, you'll see the actual element come out. But pop? I hope you don't have pop.
Yeah, because
That was
Dr. Harrison at Mayo was
70% is going to have a sore throat. I don't necessarily hear pop. I do look for when the element comes out a little bit when it's during the air, but pop. Maybe tough to go. I'm done. Negative, anything on that. What else? What do you guys have next? You got a test today? Good luck. No, I have a test before I do this lecture and everyone's training. But all right. Good luck to everybody.
Thank you.